So we are ready to start. Are you ready, sir?
Yeah, I'm ready.
Okay. So here we go. Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 15V, which is Hematology Erythrocytic Diseases. We are streaming live from the iconic IPGMER Kolkata. And we have with us Dr. Aniket Halder, who's an MBBS, MD Path, Gold Medalist, D.N.B Pathology. Presently, is an assistant professor in the Gastro-Intestinal and Liver Pathology School of Digestive and Liver Diseases, IPGMER Kolkata, with more than 25 publications in national and international journals, with areas of interest in GI path, liver path, breast pathology, and cytopathology. He has been the thesis co-guides of postgraduates and postdoctoral trainees at IPGMER. He's got ongoing projects under WBDSTBT titled Study of Intestinal Cells of Cajal in Chronic Constipation in Children of 2 years duration. He's also contributed in books, especially in Textbook of Pathology for MBBS by Dr. A.K. Mandal and Shramana Choudhury. He will be speaking on today's topic, which is primary and secondary erythrocytosis. Before I ask Dr. Halda to start, let me request all of you to keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Haldar, sir, please share your screen and let us start.
So, good evening, everyone. Am I audible, sir?
Yes, sir.
Is the screen visible, sir?
Yeah, please make it full screen. Yeah.
Yeah.
Yeah, good to go. Start, please.
Yeah. So, good evening, everyone. So, today I will talk on primary and secondary erythrocytosis. So, first, we will start with the definition and few terminology. So, what is erythrocytosis? Erythrocytosis is defined as the increase in concentration of the red cells and measured in terms of circulating red cell mass or hemoglobin or hematocrit. Now, whenever we use the term erythrocytosis, there is another term which comes in unison, that is polycythemia. Now, these two terms are often used interchangeably, but we should remember that these two terms, although similar, are not interchangeable. Erythrocytosis means there is increase in number of RBCs. So, erythrocytosis is a singular term which relates only to the erythrocytes. Whereas polycythemia, it means many cells. Poly means many and cythemia means increase in number of cells. So when we use the term polycythemia, using any we are not specifying the type of cells which are increased. So polycythemia, it is aptly used for the entity Polycythemia vera, where there is increase in red cell mass along with increase in total WBC count as well as variable increases in platelet counts. There are also certain entities like the primary familial and congenital polycythemia and Chuvas polycythemia, where this polycythemia term is being used, but in these cases there is isolated increase in the red cell mass only. So, erythrocytosis, as I had said, it is the increase in circulating red cell mass. So, how to assess whether a person has a erythrocytosis or not? So, the gold standard or the ideal way is to estimate the RBC mass, but this is quite difficult to do. So, to estimate the RBC mass, what we have to do? We have to use radio labeled RBCs. First, we have to draw 10 to 15 ml of blood from a patient. Then we have to mix it with a radioactive substance like a chromium 51, and then we have to infuse it back to that patient, and then after 45 minutes to 1 hour, we have to again draw a certain amount of blood, and we have to measure the radioactivity in that drawn blood, and then we have to multiply it with the dilution factor. So this is quite cumbersome, and it's not feasible to be practiced in our daily routine practice. Similarly, we can also measure the plasma volume by use of radio-labeled albumin, in which the radioactive substance used may be iodine 131. But these are difficult processes, and due to poor feasibility and cost effectiveness, these are not practiced. So so how do we assess erythrocytosis? We depend on the hemoglobin levels and the hematocrit levels, which are quite easily obtained in a laboratory. So what is hematocrit? Hematocrit is the volume of packed red cells in the whole blood, expressed as a percentage. So in this figure, you can see that normal hematocrit, which is about around 45% in case of males and around 42% in cases of females. So we will call it erythrocytosis when there will be increase in red cell, increase in hematocrit relative to the plasma volume. But this can be due to two causes. It can be due to absolute erythrocytosis, in which there is true increase in the red cell mass, causing an increase in the volume of the red cells, as seen in the figure C, or it can be relative, due to a depletion of the plasma volume, resulting in a relative increase in the red cell concentration. So now, if we classify erythrocytosis, we can classify it into relative erythrocytosis and absolute erythrocytosis. Relative erythrocytosis, as I had said, is due to plasma loss or plasma depletion, in which there is decrease in the total plasma volume, resulting in an apparent increase in the red cell concentration. The causes may be due to GI loss like vomiting, diarrhea, or severe dehydration, or use of loop diuretics, where there is decreased plasma volume, causing a relative increase in the red cell mass with increase in hemoglobin or hematocrit level. This relative erythrocytosis is the commonest type of erythrocytosis that we usually encounter in our daily practice. The other type of erythrocytosis is the absolute erythrocytosis, where there is true increase in the circulating red cell mass with an increase in hemoglobin or the hematocrit levels. Now, this absolute erythrocytosis can again be divided into a primary erythrocytosis, where there is an intrinsic defect in the red cells, and a secondary erythrocytosis, which is due to a secondary cause where there is increased red cell count in response to an increased erythropoietin level. So this erythropoietin can be used to differentiate between a primary and a secondary erythrocytosis. In primary erythrocytosis, as there is a primary defect in the red cells, so there will be low levels or normal levels of erythropoietin. Whereas in secondary erythrocytosis, the erythropoietin levels will be high, and due to certain secondary causes, and these causes will increase the red cell mass by increased levels of erythropoietin. The secondary erythrocytosis is often seen in hypoxic conditions, in which case this is called physiologically appropriate secondary erythrocytosis. And if this secondary erythrocytosis occurs independent of oxygen levels, then this is called physiologically inappropriate erythrocytosis. There are also certain conditions in which there is altered oxygen sensing. This altered oxygen sensing leads to increased erythropoietin levels and causes absolute increase in the red cell mass, with resulting increase in the hematocrit and the hemoglobin levels. There is another form of erythrocytosis which is called idiopathic erythrocytosis. If we cannot fit the erythrocytosis into relative or primary or a secondary subtype of erythrocytosis, we call it as a idiopathic erythrocytosis. But nowadays, with advances in diagnostic modalities, the percentage of people who are being classified as idiopathic erythrocytosis is becoming less and less. So first, starting with relative erythrocytosis, it is the commonest form of erythrocytosis that we encounter in our daily routine practice. These are low volume states in which there is plasma loss or depletion due to certain conditions like dehydration, diarrhea, vomiting, use of diuretics, or in severe burns. And these relative erythrocytosis, they can be treated very well with oral, IV fluids, or with different plasma expanders. Now moving on to primary erythrocytosis. So the two entities that I will be discussing today, which make up most of the cases of the primary erythrocytosis, are Polycythemia vera or Polycythemia rubra vera, and the second is the primary familial and congenital polycythemia. So first, the Polycythemia vera or the Polycythemia rubra vera. Polycythemia vera is a clonal hematopoietic stem cell disorder in which there is an intrinsic defect in the RBCs. It's classified in the list of myeloproliferative neoplasms in the WHO classification, and it is characterized by increased red cell production, which is independent of the mechanisms that normally regulate erythropoiesis. And this Polycythemia vera, as there is an intrinsic defect in the RBCs, the serum erythropoietin levels are low. The median age of onset of this disease is usually 60 years with a slight male preponderance, and most of the patients have panmyelosis, that is, they have trilineage hyperplasia of the bone marrow with increase in red cell as well as increase in WBC precursors as well as in platelets and megakaryocytes. So if we just recapitulate our the basic steps of hematopoiesis, so the hematopoietic stem cell is a multipotential stem cells from which the erythroid lineage cells are derived. So erythropoietin, it is produced by the peritubular renal epithelial cells. These pericytes, they produce erythropoietin, and this erythropoietin binds to the erythropoietin receptors. These erythropoietin receptors are mostly expressed in the colony forming units erythroid, the proerythroblast, and the basophilic erythroblast. So what this erythropoietin does, the erythropoietin, it binds to the erythropoietin receptors, causing downstream signaling pathways leading to the increased transcription of different genes which are involved in the proliferation, differentiation, maturation, as well as the survival of these erythroid precursors, and hence they cause the increased differentiation and maturations of the cells towards a normal RBC. So if we look at the erythropoietin and erythropoietin receptor interaction, when erythropoietin binds to the erythropoietin receptors, there is multimerization of the erythropoietin receptors causing activation of the JAK2 protein. This JAK2 molecule, once activated, it undergoes phosphorylation and it phosphorylates the adjacent JAK2 molecules. This JAK2 phosphorylation causes further phosphorylation and activation of the cytoplasmic tails of these erythropoietin receptors, causing an intrinsic tyrosine kinase activity along with phosphorylation of different downstream signaling pathways, which includes the MAP kinase pathway, the PI3 kinase pathway, and the STAT5 pathway. So phosphorylation of STAT5 pathway leads to dimerization of the STAT5 molecule, and this dimerization causes the STAT5 molecule to translocate to the DNA, translocate to the nucleus, and bind to several target genes with upregulation and transcription of these genes. So these target genes, they cause the survival, proliferation, maturation of the different proteins and different cytokines which are responsible for the differentiation and maturation of the red cells. Some of the target genes are the BCL2L1 genes, the ID1 genes, the TRP3 gene, the SPI2A gene. These prevent the apoptosis of the late-stage erythroblast with promotion of the erythroblast expansion, the survival of the erythroblast, and causes the increased production of the red cells. So what happens in Polycythemia vera is that there is a mutation in the JAK-STAT signaling pathway. The most common mutation encountered in Polycythemia vera is the mutation uh, in the 617 location, in which the valine is replaced by a phenyl allele, causing the intrinsic activation and phosphorylation of the JAK2 molecules. So in these cases, when there is a JAK2 mutation, there is activation and phosphorylation of the cytoplasmic tail of the erythropoietin receptors, even in absence of the erythropoietin. So this causes downstream signaling pathways, leading to the activation of the STAT5 molecules, which in turn translocates to the nucleus, causing transcription of different target genes which are required for the survival, maturation, and proliferation of the red cells. So in JAK2 mutation, so if there is JAK2 mutation, there is this downstream signaling pathways in absence of erythropoietin. The other common, the other mutations which are encountered in Polycythemia vera include mutations in the exon 12 and TET12 mutation. But the JAK2 V617F mutation is the most common mutation found in cases of Polycythemia vera, in which they may be found up to 95% cases. So, what is the pathophysiology of or mechanism of the different derailments that we see in Polycythemia vera? The main problem with Polycythemia vera is the increase in number of circulating red cells. So increase in number of circulating red cells will increase the viscosity of blood. Now, if we go to our high school days and just remember the Poiseuille's law, it states that the rate of flow of a liquid through a tube is directly proportional to the radius or the diameter of the tube raised to the power 4, and inversely proportional to the viscosity. So if the viscosity increases, there will be decreased rate of flow. So as the viscosity increases in Polycythemia vera, the rate of flow through a particular blood vessel decreases, and there is stasis. So by the virtuous triad, we know that if there is increased stasis, there will be increased chances of thrombosis. So in Polycythemia vera, the main problems are the different thrombotic complications. Such thrombotic complications leads to arterial thrombosis, which may cause thrombosis in the coronary arteries, resulting in myocardial infarctions. It may also cause thrombosis in the cerebral arteries, causing ischemic strokes. There can also be venous thrombosis. As I had said, that this rate of flow is directly proportional to the radius of the vessel. So smaller the radius of a particular vessel, there will be decreased rate of flow and increased stasis, leading to more chances of thrombosis. So these venous thrombosis, they are more common in small veins of the terminal of the peripheral limbs. They may be also, this venous thrombosis may be also seen in smaller venules and veins like the hepatic veins. There have been case reports where Budd-Chiari syndrome and hepatic vein thrombosis may be the first manifestation of a Polycythemia vera. So apart from this, there may be thrombotic complications in different microvasculature. So apart from the thrombotic complications, there are different vasomotor symptoms due to this hyperviscosity. Hypertension, we know that if there is increased viscosity, there will be increased peripheral resistance, and hypertension is the product of cardiac output and peripheral resistance. So more the peripheral resistance, there will be increase in blood pressure causing hypertension. There will be dizziness, blurred vision, tinnitus, and headache. These are all due to viscosity, hyperviscosity. There will be redness of the skin due to enlargement of the vessels of the distal limbs, and there may be even formation of microthrombus in the peripheral vessels, causing pain, redness, itching, and burning sensation in the peripheral limbs, as shown in this figure. This is known as erythromelalgia. There can be increased cell turnover because as there is increased production of red cells, there will be increased cell turnover causing gout. There will be increased histamine release. This histamine release, it is postulated that in Polycythemia vera there is increase in basophil count, which causes the increased release of histamine, causing different manifestation. One is the gastric ulcers due to this increased histamine acting on the gastric parietal cells, causing increased acid secretion and hence gastric ulcers. There is another entity called aquagenic pruritus. This is if a patient of polycythemia takes a hot shower, then they manifest severe itching in the body. This is implicated. This is thought to be due to increased histamine release after a hot shower, and this entity is called aquagenic pruritus. So, apart from this, there can be different bleeding manifestations due to increased platelet count and consumption of the platelet in thrombus formation. And lastly, there can be hepatosplenomegaly due to congestion of the liver and spleen due to this increased red cell mass. Now, if we go to the WHO criteria, there are some major criteria and a minor criteria. Now, the major criteria, major criteria are hemoglobin levels more than 16.5 gram per dl or in males, or more than 16 gram per dl in females, or a hematocrit of more than 49% in male, or hematocrit more than 48% in women. The second criteria gives importance to the bone marrow biopsy findings, where there will be trilineage hyperplasia with panmyelosis. That is, there will be increase in the red cell, in the white blood cells, as well as the platelets and their precursors, and there will be presence of pleomorphic mature megakaryocytes. By the term pleomorphic, it indicates that there will be mature megakaryocytes of different sizes, but the presence of atypia will be lacking. And the third major criteria is the presence of a JAK2 mutation, most commonly the JAK2 V617F mutation. The minor criteria of the WHO 2016 criteria is the subnormal serum erythropoietin levels. For diagnosing polycythemia vera, all three major criteria has to be present, or the first two major criteria along with the minor criteria will suffice to diagnose a case to be polycythemia vera. It has been also given in the footnote in the WHO criteria that bone marrow biopsy may not be required if there is persistently increased hemoglobin levels of more than 18.5 gram per dl in men, or more than 16.5 gram per dl in women, provided the third major criteria, that is JAK2 mutation, and is present along with low serum erythropoietin levels. Now, if we just compare the 2016 criteria with the 2008 criteria, we can see that some important changes have been done. In the 2008 criteria, the hemoglobin level of more than 18.5 gram per dl and in case of male, and more than 16.5 gram per dl in cases of women was used. Whereas in the WHO 2016 criteria, the levels have been decreased. So this reduction in the hemoglobin or hematocrit levels for diagnosing polycythemia vera has been done to prevent the underdiagnosis of the polycythemia vera cases. The second important change is the inclusion of the bone marrow morphology in the 2016 WHO criteria. This has been done because it has been seen that the polycythemia vera has early or masked polycythemic phase, in which there can be only mild erythrocytosis in routine investigation and the peripheral blood smear. But if we do a bone marrow biopsy, there can be presence of panmyelosis with trilineage hyperplasia. So, for identification of the masked polycythemia vera, the importance of bone marrow morphology has been included in the major criteria. And thirdly, there was a criteria in which of endogenous erythroid colony formation in absence of erythropoietin. So this criteria has been removed because in our routine practice, it has limited practicality. It is a costly affair, and also standardization is not available. Now, the phases of polycythemia vera, as I had said, the polycythemia vera can have a pre-polycythemic vera phase, which is a prodromal or mast phase with only mild erythrocytosis. The overt polycythemic vera, polycythemia vera phase, where there is marked erythrocytosis with characteristic bone marrow changes, as I had said, trainees, hyperplasia with panmyelosis and presence of pleomorphic mature megakaryocytes. And third is the post-polycythemia vera myelofibrosis, which is also called the spent phase of polycythemia vera, in which there will be cytopenias, which include anemia. This anemia is due to ineffective erythropoiesis and also due to increased fibrosis in the bone marrow. This increased bone marrow fibrosis will lead to extramedullary hematopoiesis with resulting hepatomegaly and splenomegaly, and later this splenomegaly will again cause anemia by virtue of hypersplenism. So just if we look at the peripheral blood smear of a case of polycythemia vera, there will be increased population of the red cells and increased overlapping and density of the red cells as seen in the figure. Now, if we look at the bone marrow of a overt polycythemia vera, we will find a very hypercellular marrow, as is seen here, with only few fat spaces being seen, and there will be panmyelosis with predominance of the erythroid precursors and the megakaryocytic precursors. So these megakaryocytes, they will be mature hyperlobulated forms, and there will be the pleomorphism. In this case, pleomorphism refers to the difference in size of the megakaryocytes rather than any atypia. And if we do a reticulin stain, we can find minimal reticulin fibrosis. Reticulin fibrosis is usually of grade 1 in polycythemia vera, and we can also see the matured hyperlobulated megakaryocytes without any atypia. So this is a picture of a post-polycythemia vera myelofibrosis, in which we can see a bone marrow which has been replaced by extensive amount of fibrosis with intersecting fibrosis, and there is also marked decline in the hematopoietic cells. If we do a peripheral blood smear, we can often find leukoerythroblastosis. That is, we will find different myeloid precursors, and also we will find the nucleated RBCs in the peripheral smear. Now, blasts in post-polycythemia vera myelofibrosis, blasts may rarely increase, but it is usually less than 10%. If the blast percentage in the bone marrow is more than 10%, and if there is presence of dysphasia in the different cell precursors, then we have to consider myelodysplastic syndrome, and if or an accelerated phase of AML. And if there is more than 20% blast in the bone marrow, then the AML should be considered. Now, this is the fibrosis that is seen in post-polycythemia vera myelofibrosis. In the left, we have a reticulin stain has been done, where we can see intersecting dense reticulin fibrosis. And there is a mesenteric stain on the right side, where we can see the dense collagen fibrosis, as demonstrated by the blue fibrous bands in the mesenteric stain. Now, to diagnose a post-polycythemia vera myelofibrosis, WHO has laid some specific criteria, in which the two criteria that are required for diagnosis is the documentation of a previous diagnosis of WHO-defined polycythemia vera. That means all the criteria of polycythemia vera should be there, and a patient should be a known case of diagnosed polycythemia vera, along with moderate to marked fibrosis. So bone marrow fibrosis of grade 1 or grade 2 will not suffice. it has to be grade 2 to 3 on a 0 to 3 scale, or if it is graded in a 0 to 4 scale, the grade of fibrosis should be at least 3 to 4 with marked intersection of the fibers. And additionally, there has to be 2 criteria present among the 4 criteria, which are anemia, leukoerythroblastosis, increasing splenomegaly, and constitutional symptoms. Among the constitutional symptoms, at least 2 features should be present, which includes night sweats, unexplained fever, and weight loss more than 10% in the last 6 months. So, presence of these 2 required criteria along with 2 of the 4 additional criteria will only help us to diagnose a case of post-Polycythemia Vera myelofibrosis. So now going on to the treatment of Polycythemia Vera, the goals of therapy in Polycythemia Vera is to decrease the thrombotic complication, to prevent the progression of disease, and to prevent the progression to a MDS or a AML or a post-Polycythemia Vera myelofibrosis, and thirdly, to decrease the symptoms of the patients. So before starting the treatment, each patient should be stratified into a low risk or high risk group depending on the age of the patient and a prior history of thrombosis. So if a patient has a prior history of thrombosis and if he is aged more than 60 years, then he should be classified as a high risk patient. And the mainstay of therapy in Polycythemia Vera includes therapeutic phlebotomy, in which 1 unit of blood should be taken out every weekly till the target hematocrit levels of less than 45% is achieved in cases of males and less than 42% in case of females. And the other therapy that is used in Polycythemia Vera includes cytoreductive therapy, in which different cytoreductive agents like hydroxyurea or JAK2 inhibitors or interferons may be used. And thirdly, symptomatic therapy should be provided. For example, if there is erythromelalgia, the patient should be treated with aspirin. If there is hypertension, that should be taken care of. Increased uric acid levels should be treated by febuxostat or allopurinol, and likewise. So after this stratification that I already said, if the patient has low risk, we have to take care of the different cardiovascular risk factors, and we have to prevent thrombotic complications. Low dose aspirin should be used, and phlebotomy should be used to take out blood and decrease the red cell concentration and the hematocrit levels. And target values should be less than 45% in cases of males and less than 42% in cases of females. In high risk patients who are more than 60 years of age with prior thrombosis, cytoreductive therapy should be used frontline with hydroxyurea, which is the anti-metabolite, or interferon alpha. The second line therapy can be with ruxolitinib, which is a JAK2 inhibitor. And in cases where there is associated thrombocytosis, busulfan, anagrelide can be used. And the patients, the low risk patient, they should be progressively kept under follow-up to see if there is increasing leukocytes or platelet counts. They should be monitored and kept under watch to see if there is enlarging spleen, or if there is uncontrolled disease symptoms, or if they are poorly tolerating phlebotomy, then they should be given a cytoreductive therapy. The clinical outcome of Polycythemia Vera, usually with treatment, the prognosis is good and median survival is more than 10 years. Thrombosis, hemorrhage are the main causes of death, and it is seen in 15% of cases if the patients are not under therapy. About 20% of cases can advance to post-Polycythemia Vera myelofibrosis at 10 to 15 years after diagnosis. And it has been also seen that in a small percentage of patients, less than 10% of patients, after 20 years, the patients may advance to a MDS or a AML. And this is common if the patients are treated with cytoreductive agents at the first place. So these are the risks. So cytoreductive agents are the risk factors for a polycythemic vera patient advancing to a AML or a MDS. Prognosis. So this is a large series by Teferi et al., where in his original article he showed that patients older than 67 years of age and patients having persistent leukocytosis more than 15,000 with with multiple episodes of venous thrombosis and abnormal karyotype usually have a poorer prognosis. So now, after completing polycythemia vera, the other type of primary erythrocytosis is a congenital defect or a congenital disease, which is called primary familial and congenital polycythemia, or PFCP. So it is an autosomal dominant disorder in which there is no mutation in the JAK2, there is no JAK2 mutation, but there is mutation in the genes which encode the erythropoietin receptor. So these mutations in the erythropoietin receptor genes causes a hypersensitivity of the erythropoietin receptor to erythropoietin. So even in presence of normal levels of erythropoietin, there is increased JAK-STAT signaling, leading to increased red cell count, causing erythrocytosis. And in these cases, usually splenomegaly will be absent, and leukocytosis or thrombocytosis is also not found in these cases. In this aspect, I should also mention that there was a famous Finnish cross-country skier called Eero Mentirenta, who had won seven Olympic medals in the Winter Olympics, and from 1960 to 1972, and it was later discovered after 20 years in around 1993 that this famous personality had this primary familial and congenital polycythemia, by virtue of which he had increased hemoglobin and increased red cell count in his blood, and it was then speculated that possibly it was due to this increased red cell mass, which helped him immensely, because it increased the oxygen carrying capacity, and hence it might have helped him to win 7 Olympic medals in 4 Winter Olympics. So after primary erythrocytosis, let's move on to the next entity, that is secondary erythrocytosis. So secondary erythrocytosis, as I had said, it is due to increase in erythropoietin with resulting increase in red cell mass. So this increased erythropoietin can be seen in certain cases in which there is presence of chronic hypoxemia, and this chronic hypoxemia induced secondary erythrocytosis is called physiologically appropriate response, and this can be seen in people living at high altitude, in children who have congenital cyanotic heart diseases or right to left shunts, in chronic lung diseases like COPD or chronic asthma, in patients of hypoventilation with sleep apnea syndrome, in obese patients, in heavy smokers who have raised carbon monoxide levels, and in high affinity and patients carrying high affinity hemoglobin, for example, hemoglobin San Diego. This secondary erythrocytosis can also be caused independent of oxygen, in which case it is termed as a physiologically inappropriate response, and it is seen in defined erythropoietin secreting tumors like renal cell carcinomas with aberrant secretion of erythropoietin, or hepatocellular carcinomas with increased secretion of erythropoietin causing increased red cell mass, in different kidney disorders, in conditions where there is decreased levels of 2,3-BPG, because 2,3-BPG causes a left shift of the oxygen hemoglobin dissociation curve and increases the affinity of hemoglobin to oxygen, leading to tissue hypoxia. And iatrogenic causes may be due to exogenous use of steroids or exogenous administration of erythropoietin or testosterone, because it directly increases the erythropoietin levels of the blood and thus increases the red cell mass. There are also certain conditions in which there is altered oxygen sensing, which I will be discussing later in the slides, which also leads to increased erythropoietin with resultant increase in red cell mass in normoxic patients. So this is the chart for the PGTs to understand the pathogenesis, which had already discussed the pathogenesis of secondary erythrocytosis. In the left hand portion, we can see the different causes of inappropriate response, where there is increased erythropoietin production independent of the oxygen levels, and this can be seen in different renal diseases like renal stenosis, in hydronephrosis, or different renal cysts, where there is local hypoxia in the kidney. Uh, Due to this local hypoxia, there is the kidney senses the decreased oxygen, causing increased erythropoietin production. High affinity hemoglobins like the hemoglobin San Diego, they bind to the oxygen more avidly, and this leads to tissue hypoxia because the hemoglobin does not easily unload oxygen. In chronic smokers, or in people who work in different car garages, they have increased level of carbon monoxide in their blood, and this carbon monoxide binds more avidly to the hemoglobin molecule, causing resulting in forming increased levels of carboxyhemoglobin and decreased levels of the decreased oxygen carrying capacity of the hemoglobin, leading to tissue hypoxia. Different tumors like the renal cell carcinoma or hepatocellular carcinomas, adrenal adenomas, they can secrete erythropoietin in an unregulated way. This is a part of paraneoplastic syndrome. And on the right hand side, we can see the physiologically appropriate response, where increased erythropoietin production is due to chronic hypoxemic states like high altitude or obstructive sleep apnea syndrome, where there is episodic airway obstruction causing intermittent hypoxia. Cyanotic heart diseases and right to left shunts may cause shunting of blood with venous and arterial blood mixing, and resulting in poor oxygenated blood and tissue hypoxia. Chronic lung diseases like the interstitial lung diseases, COPD, chronic asthma leads to poor lung functions, leading to poorly oxygenated blood and increased episodes of hypoxia, leading to increased erythropoietin production and secondary polycythemia. And there can also be exogenous causes, as I had mentioned, different therapy with testosterone or steroids, or iatrogenic erythropoietin administration can also cause secondary polycythemia. Now, when we are discussing the secondary polycythemia, more often we encounter the chronic hypoxemic states which lead to the secondary polycythemia due to increase in erythropoietin production. So how does this hypoxia and erythropoietin levels interplay? So to know this, we have to know the hypoxia erythropoietin pathway. Normally, where the master regulator of this erythropoietin secretion is the HIF alpha molecule. The HIF stands for the hypoxia inducible factor. This hypoxia inducible factor, it is constitutively expressed and is present in virtually all nucleated cells. And this HIF or hypoxia inducible factor has two subunits. The one subunit is the HIF alpha subunit, which is present in the cytoplasm, and the HIF beta subunit, which is present in the nucleus. This HIF alpha subunit, it binds to the HIF beta subunit in the nucleus after translocation into the nucleus, with binds and forms the dimer, and this dimer then acts on the hypoxia response element, which acts as the promoter region for transcription of different target genes which are involved in angiogenesis, in oxygen independent metabolism like glycolysis, and obviously in erythropoiesis. So this binding of hypoxia inducible factor to the HRE causes transcription of increased transcription and production of the erythropoietin, which leads to increased erythropoiesis and increased red cell production. Now, what happens in normoxic conditions is that when there is normoxia, there is increased availability of oxygen. So there is this molecule which is called prolyl hydroxylase domain. So this PhD domain protein, or the prolyl hydroxylase domain protein, it hydroxylases the proline residues of the HIF alpha molecule. Once the HIF alpha molecule is hydroxylated, VHL avidly conjugates to this hydroxylated HIF alpha molecule. So this binding of VHL, or the von Hippel-Lindau protein, is the signal for ubiquitin bonding to this HIF alpha and VHL complex. So as ubiquitin binds to this HIF alpha VHL complex, there is abrupt and instant proteasomal degradation, and hence the levels of HIF alpha decreases in the cytoplasm. So in non-moxic condition, the levels of HIF alpha in the cytoplasm is always kept under control. In hypoxic condition, when oxygen is not available, what happens is that this proline hydroxylation of the HIF alpha molecule by the PhD protein does not take place. So HIF alpha molecule is free. It then translocates into the nucleus, binds to the HIF beta molecule, and then this dimer then binds to the HRE segment, which acts as the promoter for different target genes, including increased production of the erythropoietin. So this is the pathway which regulates the hypoxia, regulates the production of erythropoietin in hypoxic conditions. Now the role of HIF molecules acting on the hypoxia responsive element was known almost for last 20 to 30 years. But the key role of von Hippel-Lindau protein in this pathway was unknown. And for the discovery of the role of this tumor suppressor protein VHL in this degradation of the HIF alpha molecule and regulation of the hypoxia erythropoietin pathway is very significant, and these three gentlemen, Mr. William G. Kaelin Jr., Sir Peter Ratcliffe, and Sir Greg Semenza, had been given Nobel Prize for Physiology or Medicine in 2019 for correlating and for designing this pathway, which aptly describes the hypoxia erythropoietin interplay. Now, after we have known the PhD HIF VHL pathway, there are certain conditions in which there is altered oxygen sensing. This altered oxygen sensing can be seen in different conditions, of which the first is the Chouas polycythemia. This Chouas polycythemia is named after this entity being first diagnosed in people living in Chouasian Republic of the Russia, of the Russian Federation, where homozygous mutation of the VHL gene has been found in this population. So these people with Chouas polycythemia have been found to have ruddy cyanosis and elevated levels of red cell mass. So this is due to the mutation of VHL gene. So mutated VHL gene does not bind to the HIF alpha molecule, and so this HIF alpha molecule this binds to the HIF beta molecule, resulting in the increased erythropoietin production. There is another erythrocytosis called PhD2 erythrocytosis, where there is loss of function mutation of the PhD2 molecule. So in absence of the PhD2 molecule, the proline hydroxylation of the HIF alpha molecule does not occur, and so the levels of HIF alpha molecules in the cells is persistently increased, leading to increased levels of erythropoietin with increased red cell production. And the third is the HIF2 alpha erythrocytosis. HIF alpha has many isoforms, of which HIF2 alpha is the most important isotype, and gain of function missense mutations in the HIF2 alpha molecule causes impaired hydroxylation of the HIF2 alpha. Because if there is a gain of function mutation, this HIF alpha, it escapes the degradation and binding of the VHL molecule. So if VHL molecule cannot bind to this HIF2 alpha molecule, it easily translocates into the nucleus, causing increased transcription and increased production of erythropoietin, resulting in erythrocytosis. And this PhD2 exocytosis and HIF2 alpha erythrocytosis has also been associated with paragangliomas and pheochromocytomas. So these are the mechanism of altered oxygen sensing. These are very rare entities, but these are defects in the PhD HIF VHL axis, which causes the increased erythropoietin levels and increased red cell production in these patients. So, coming to the management of secondary erythrocytosis, the mainstay of treatment of patients with secondary erythrocytosis is correcting or eliminating the cause. In cases of chronic hypoxemia related erythrocytosis, the patients should be given low flow oxygen. Patients with lung diseases or COPD should be given low flow oxygen with corrective therapies. Patients with chronic hypoxemia with persistently raised RBC mass with increased hematocrit may also be given subjected to phlebotomy, but this depends on the extent of the increased hematocrit and the complications or the manifestations of the patients. Patients who are chronic smokers or who have obesity or hypoventilation or apnea syndrome, they should be given lifestyle modifications. The patients with renal or hepatic lesions should undergo corrective surgeries. Patients with tumor should also undergo surgery to remove the lesion which is causing the secondary erythrocytosis. Patients with renal artery stenosis should undergo surgeries or implantation of stents. Familial causes of secondary erythrocytosis, no specific treatment is available, but symptomatic treatment should be used in such patients. Phlebotomy may be used to decrease the blood volume wherever relevant. So going on to the last part of the discussion, how should we evaluate erythrocytosis? So if a patient of erythrocytosis comes to us, he will have persistently raised hemoglobin or hematocrit. So the first and foremost thing should be a proper history and a proper clinical examination of the patient, because if we take proper history, we can eliminate the cause of this erythrocytosis, because in majority of the cases, as I had said, in majority of the cases are due to relative erythrocytosis, in which there is a decrease in the plasma volume causing an increased concentration of red cells, which resulting increase in hematocrit or the hemoglobin levels. Also, the clinical examination should be done. Proper clinical examination should be done. CBC is the mainstay of diagnosing erythrocytosis, in which there will be increased hemoglobin or an increased hematocrit levels. As per the recent WHO criteria of 2016, as I had said, the hematocrit levels should be more than 49% in cases of male. It should be more than 48% in cases of females. And the hemoglobin level, which was previously 18.5 gram per DL in case of males and 16.5 gram per DL in case of females, the threshold has been decreased, and persistently raised hemoglobin levels of more than 16.5 gram per DL in case of males and more than 16 gram per DL in case of females should be evaluated. Now, in our setup, in our country, if we are to choose between serum erythropoietin levels and JAK2 mutational status, then we should first go for a serum erythropoietin level estimation, because if we go for a serum erythropoietin level estimation, we can easily differentiate between a primary cause of erythrocytosis and a secondary cause of erythrocytosis. If the serum erythropoietin level is low or normal, then we can go for a JAK2 mutational status to look for any JAK2 mutation. And if there is increased serum erythropoietin levels, then we have to consider secondary erythrocytosis. And the secondary erythrocytosis, we can again differentiate into a physiologically appropriate or an inappropriate erythrocytosis by measuring the SpO2 levels. So, if the SpO2 levels are persistently less than 92%, it indicates that the secondary erythrocytosis is due to a chronic hypoxemic state, whereas increased SpO2 levels more than 95% usually indicates that there is a physiologically inappropriate response and there is some underlying condition which is causing this increased erythropoietin in absence of hypoxia. We can also perform arterial blood gas analysis, mainly in hospitalized patients, to differentiate between a physiologically appropriate or a physiologically inappropriate type of secondary erythrocytosis. Red cell mass estimation is not practiced routinely, and use of 51 chromium RBCs can be done for red cell mass estimation, but it should only be considered in JAK2 negative patients who have persistently low erythropoietin level but increased hemoglobin and hematocrit levels. In such patients, a red cell mass estimation may be carried out to see to look for absolute or true erythrocytosis. So finally, the overview of the approach and treatment of a patient of erythrocytosis, a persistently elevated hemoglobin or a hematocrit level. First, we should consider and exclude causes of relative erythrocytosis like use of diuretics or dehydration or diarrhea or severe vomiting or other causes of relative erythrocytosis. After we have excluded relative erythrocytosis, we should go for a serum erythropoietin level and a JAK2 V617 mutation. So if the JAK2 mutation is positive, Polycythemia vera is confirmed, we should refer the patient to the hematology team and the appropriate therapy should be given. If the patient is JAK2 negative, but if he has increased erythropoietin level, then we should consider secondary polycythemia. As I had said, physiological, whether if it is physiologically appropriate, we have to look for evidence of hypoxia. In such cases, the SpO2 levels will be low, and we have to investigate for underlying cardiac or respiratory causes of hypoxia. We have to treat the underlying cause, and in refractory cases or patients who have symptoms, we can even consider venesection or phlebotomy, and the target hematocrit should be less than 45%. Inappropriate erythropoietin secretion, if suspected, where the SpO2 levels will be more than 95%, we have to consider and exclude different paraneoplastic conditions where there is aberrant erythropoietin secretion. We have to perform ultrasound, chest X-rays, and CT scans to exclude any erythropoietin secreting tumors like renal cell carcinoma, hepatocellular carcinoma, leiomyomas, adrenal adenomas. We have to also evaluate the patient for other diseases that may cause inappropriate erythropoietin secretion. If the erythropoietin levels are low and the patient has a JAK2 negative, and if there is JAK2 negative, then we have to consider JAK2 negative polycythemia vera. In such case, we have to first exclude the secondary causes, and after excluding the secondary causes of polycythemia, we have to do bone marrow sampling to look for the bone marrow, to see the bone marrow changes, and in such cases only we can also opt for a red cell mass, and the patient can be treated in line of polycythemia vera, JAK2 negative polycythemia vera. So, the summary of today's discussion: erythrocytosis is the increase in concentration of circulating red cell mass, which can be reflected as increase in hemoglobin or hematocrit levels. It is although used interchangeably with polycythemia, but it is not synonymous with polycythemia. The correct term should be erythrocytosis. In cases where there is trilineage, there is increase in all the three cell lineages, that is increase in red cell mass associated with increased WBCs and platelets. The word polycythemia should be used. Polycythemia vera is one such condition where there will be increased red cell mass along with variable increases in WBC or platelet counts. Erythrocytosis may be relative or absolute. Relative erythrocytosis is the commonest type of erythrocytosis. Absolute erythrocytosis can be classified as primary and secondary. The serum erythropoietin level estimation differentiates the primary from secondary erythrocytosis, because in primary erythrocytosis, the main defect is in the red cells, whereas in secondary erythrocytosis, there is a chronic hypoxic condition or inappropriate erythropoietin secretion, which leads to increased erythropoietin levels and hence increased red cell mass. Polycythemia vera, it's a clonal hematopoietic stem cell disorder, which is categorized as myeloproliferative neoplasm in the WHO classification. JAK2 mutations are the driving factors for most polycythemia veras, and JAK2 V617F mutation is found in more than 95% patients of polycythemia vera. Bone marrow histology is very important criteria and has been now included in the major criteria of polycythemia vera, where we can find trainees hyperplasia with panmyelosis, where there is increase in erythrocytic, granulocytic, as well as the megakaryocytic lineages, and there will be presence of pleomorphic mature megakaryocytes, but megakaryocytic atypia will be lacking. And lastly, the treatment of erythrocytosis should be symptomatic, and treatment of the underlying etiology along with phlebotomy in intractable cases of erythrocytosis. In cases of polycythemia vera, cytoreactive therapy should be given in high-risk patients, and also in refractory cases of erythrocytosis, the cytoreactive therapy may be used. So, thank you.
Thank you, Dr. Aniket. Very nice presentation and to the point.
Thank you, sir.
And it is very important for us to understand that we try to synonymously use
Yeah, sir.
polycythemia vera and erythrocytosis, thinking to
Yes,
be
sir.
the same. And the two key takeaways are the erythropoietin level and the JAK2 mutation
Yes, sir.
status.
Yes, sir. So,
They are
in
the
our,
decider.
yes, sir. In our setup, I think the serum erythropoietin level should be first estimated to
Yeah,
differentiate between a primary and secondary.
absolutely,
And if
absolutely.
it's normal or low, then we should go for a JAK2
And we should
mutation,
go for a
because
JAK2.
it's costly and
Exactly.
it's not available everywhere.
Absolutely right. And very nicely explained. Very, very well done. Excellent job.
Thank you, sir.
Dr. Aniket, we will invite you again for some other lectures in maybe cytopathology or maybe in other subjects.
Sure, sure, sir.
You're a very good teacher. Wonderfully done.
Thank you, sir.
Try to join in on the 10th of February. We have a lecture on NPN,
Yes,
where
yes,
Dr.
sure.
Karthikeya will be speaking on polycythemia vera and all the other aspects of NPN.
Thank you, sir.
It will
Thank
be
you. I
it will
will
be a
definitely.
continuation of your lecture. Right.
Yes. Thank you, sir.
Thank you. Take care. Bye bye. Good night.
Good night, sir.
Good night. Bye.